Today, we're going to tackle a really common clinical question: antibiotic prophylaxis for colonoscopy. You know, it's this constant balancing act, right? We want to prevent a rare but potentially catastrophic infection, but we're also facing the very real dangers of antibiotic overuse and resistance. For years, our practice was honestly guided more by a sense of caution than by hard data. But now, we have a mountain of evidence that has totally reshaped our approach. So, let's follow that evidence and see how this entire paradigm shifted. Here's how we'll break it down. We'll start with the old rationale, why we used to do what we did. Then we'll make a really surprising comparison between the procedure and just daily life. We'll redefine what it actually means to be a high-risk patient, look at the modern guidelines, and then apply all that knowledge to a couple of clinical cases. And finally, we'll tie it all back to the incredibly important principle of antimicrobial stewardship. For the longest time, the thinking was pretty straightforward. An endoscopy could, in theory, push bacteria into the bloodstream. So giving antibiotics just in case seemed like a smart, prudent precaution. This whole approach was really rooted in this cautious desire to prevent any possible infection, especially that dreaded complication, infective endocarditis. And this was the question that drove everything. The stakes felt incredibly high, and when you don't have definitive data, what do? Well, the default was to treat, just in case. And this really established a kind of ritual of prophylaxis that we're now re-examining through the lens of modern science. So what was the evidence that caused such a massive paradigm shift? Well, it all starts with understanding a concept called transient bacteremia, which is just a fancy way of saying the temporary presence of bacteria in the blood. And where this bacteria comes from, well, it's often quite surprising. Just look at this number for a second. 68%. What activity could possibly cause bacteria to enter your bloodstream, and 2 out of every 3 people who do it? It's not some major medical procedure, it's just brushing your teeth. Now, this is where it gets really interesting. This slide shows the stark contrast. The bacteremia rate from something as simple as toothbrushing can be as high as 68%. From chewing your food, up to 50%. Now compare that to a colonoscopy, which has a mean incidence of just 4.4%. I mean, it's not even close. This one comparison just fundamentally blows up the old rationale for routine prophylaxis. And this quote just brilliantly captures the point. The cumulative exposure to bacteremia from just living your life, brushing your teeth, eating, that's the entire ocean of risk. The single, brief bacteremic event from a colonoscopy, well, by comparison, it's just one drop. Realizing this was a key driver behind the change in guidelines. Okay, so if the procedure itself isn't the main problem, what is? The focus is now completely shifted from the risk of the procedure to the vulnerability of the host, the patient themselves. The real determinant of infection risk often lies within the patient's own body. The key mechanism we're talking about here is something called bacterial translocation. This is how gut bacteria, which are totally harmless in the gut, manage to cross the intestinal wall and get into the sterile bloodstream. And this can happen from the minor mechanical trauma of an endoscope, sure, but more importantly, it happens when that gut barrier is already weak to begin with. So here's the crucial point. A clinically significant infection is almost never the result of the procedure alone. It's much better to think of it as a 2-hit event. The first hit is a compromised host, someone with a severely weakened immune system or a diseased gut. The second hit, that's the procedure, which provides that little drop of transient bacteremia. Without that first hit, that second one is almost always harmless. This brings us to a really important question. Who is a truly high-risk patient? Modern guidelines have narrowed this down to a very specific, very small group of cardiac conditions where an infection would have the absolute worst outcomes. We're talking patients with prosthetic valves, a prior history of endocarditis, and some very specific congenital heart defects. Importantly, things like pacemakers, stents, or mitral valve prolapse, they're no longer considered indications for prophylaxis. That list got a lot shorter. So, armed with this new understanding of risk, the clinical guidelines went through a massive evolution. And this wasn't just a minor tweak, it was a fundamental shift in practice. We moved from this broad, cautious approach to a restrictive, evidence-based, and precise one. You can actually see the progression right here. It started in the 1960s with these broad, theory-based recommendations, but the critical turning point was 2007. The American Heart Association published these landmark guidelines that, based on the evidence we've just talked about, massively scaled back the use of prophylaxis. And that led to the international consensus we have today. And this is it. This is the single most important takeaway. The modern guideline is completely unambiguous. For a routine diagnostic or therapeutic colonoscopy, antibiotic prophylaxis to prevent endocarditis is not recommended. And here's the kicker. This holds true even for those patients in the absolute highest risk cardiac categories. Okay, so we have the theory and we have the guideline, but let's see how this all plays out in the real world, in the clinic. I'm going to walk you through two cases to really help solidify these concepts. All right, here's our first case. We have a patient with a prosthetic valve, which puts her squarely in that high-risk cardiac group we talked about. She's coming in for a routine surveillance colonoscopy. Based on everything we've just learned, what's the correct strategy? If you said C, no prophylaxis, you are absolutely correct. And understanding the reasoning behind this is crucial. So yes, her cardiac condition is considered high risk. But the guidelines are crystal clear that for this specific procedure, a colonoscopy, the risk of actually causing endocarditis is so vanishingly small that it simply does not justify the risks of giving an antibiotic. Now let's try a more complex case. This patient also has a high-risk cardiac condition, a mechanical valve. But there's a second, crucial piece of clinical information here. She's on peritoneal dialysis. So if we do decide to give antibiotics, what exactly are we trying to prevent? The correct answer here is C. We do give prophylaxis, but the key is understanding why. And the goal here is to prevent peritonitis. This is where clinical nuance is so incredibly important. We are not giving her antibiotics because of her heart valve. The guideline has ruled that out. We are giving them because of a completely separate risk. We know that a colonoscopy can cause peritonitis in patients on peritoneal dialysis. The goal is specific, and our reasoning has to be precise. This summary table is a fantastic tool to have. It clearly shows that big, bold no for routine colonoscopy, regardless of cardiac status. But it also highlights the specific yes scenarios, and each one has a different targeted goal. We're preventing peritonitis in dialysis patients, preventing wound infections for PEG 2 placements, or preventing cholangitis in an ERCP with biliary obstruction. It's all about matching the right indication to the right goal. All right, finally, let's just zoom out for a second. This entire discussion is about so much more than just a single procedure for a single patient. It's really about a core principle of modern medicine: antimicrobial stewardship. By following this evidence, we're doing more than just avoiding an unnecessary medication. We reduce the risk of allergic reactions, of C. diff infections, and most importantly, we are fighting the global crisis of antimicrobial resistance. This isn't just about best practice anymore. It's about our collective responsibility. So every time we choose not to give an unnecessary antibiotic, we provide the best, safest care for our patient today, and we help protect the future of medicine for everyone.